Hello, everyone, and welcome to today's webinar. My name is Olga Bodie, and I'm a SYNGAP parent and part of the team here at SYNGAP Research Fund. Our presentation today is SYNGAP1 and epilepsy surgery. Is it time to consider a different toolbox? And I have the pleasure to introduce today's speakers, Monica Jones, JD, and Dr. Abel Taylor. Monica is founder and executive director of the Pediatric Epilepsy Surgery Alliance, formerly known as the Brain Recovery Project. She is also the principal investigator of the Global Pediatric Epilepsy Surgery Registry, the only patient-powered by parent proxy study to understand the developmental trajectory after epilepsy surgery. Dr. Taylor Abel is a pediatric neurosurgeon specializing in epilepsy surgery. He is surgical director of the Pediatric Epilepsy Surgery Program at UPMC Children's Hospital of Pittsburgh and is a highly published researcher on epilepsy surgery, including neuromodulation. Excuse me, sorry. He also sits on the scientific advisory board for the Pediatric Epilepsy Surgery Alliance. A recorded version of this webinar will be available on the SRF website under webinars on the family menu. And by the end of this presentation, you will have the opportunity to answer your questions. We'd love to hear from you, and if you can put those questions in the Q&A. And for those of us just joining you, welcome. And again, our speakers today are Monica Jones and Dr. Taylor Abel. Their presentation today is SYNGAP1 and epilepsy surgery. Is it time to consider a different toolbox? It's now my pleasure to turn things over to Monica. Thank you.
Thank you very much. Let me get my presentation up. I didn't quite cue it appropriately here. I hope you can all see it. Can you see the presentation?
Yes.
Great, terrific. I'm Monica Jones. I just wanted to say how fortunate we are to have Dr. Abel with us. He is a highly trained epilepsy surgeon. You know, I like to say they're a neurosurgeon and then there are highly trained pediatric epilepsy surgeons, and that's who Dr. Abel is. So we're very spoiled that he's on our scientific advisory board and very excited that on really short notice he decided to join us for this webinar. I'm a hemispherectomy mom. My son has had the left half of his brain removed to stop seizures, and I'm very passionate about making sure that parents understand that surgery is a treatment for drug-resistant seizures that they should be considering at least. When we think about epilepsy treatments, we have to think about them as being in three different toolboxes. The first toolbox that your doctor, your child's neurologist will go into is obviously the medical toolbox, the medicines. If medicines don't work, then you're supposed to be referred to go to see if one of the tools in the surgery toolbox works. And then if you're not a candidate for one of the resective surgeries, the surgeries where they remove or destroy part of the brain, then we would look at neuromodulation devices, which we'll talk about today, or diet. The International League Against Epilepsy, which is really the premier global body of neurologists and neurosurgeons who set these standards that our doctors published a very important paper last year, and where they said really anyone up to about age 70, every single patient, as soon as they're drug resistant, regardless of how long they've had the epilepsy, regardless of how much money they have, the type of insurance that they have, regardless of their seizure type, regardless of any of these things, they should be referred for a surgical evaluation. So then the question is, well, then what is drug resistance? And that is a really easy formula to remember. A child is drug resistant if they have failed 2 appropriate and tolerated anti-epileptic drugs. If your child gets a rash from an anti-epileptic drug, they're not considered tolerated, so you wouldn't count that medication. Or if they have a drug that's not really appropriate for the type of epilepsy your child has, let's say they're having absence seizures and they're given a medication that's not really indicated for absence seizures, they wouldn't count. But otherwise, when they have failed 2, you're supposed to be referred for a surgical evaluation. And that generally doesn't happen often. I'm sure there are a lot of parents out there who are experiencing yet another medication, a third, a fourth being thrown at them, and no discussion about surgery has been made yet. So we just want to open up that door for you to start considering opening up that surgery toolbox to see what's in there that might help your child. Epilepsy surgery is not a last resort. You'll see this on our Twitter. You'll see me talking about this. Does this mean that I'm saying today you need to go in and make sure that your child gets surgery? No. All I'm saying is get a referral for a surgical evaluation so that together with your team, you can open up that toolbox and have the evaluations needed to see which tool might be able to help. So today, we're just going to briefly talk about what epilepsy surgery is. I like to think of them as going into 4 different buckets: surgeries that remove part of the brain, destroy part of the brain, disconnect part of the brain. There are also surgeries that technically are not considered epilepsy surgery, but we put them into that overall toolbox. And there's a lot of literature that starts to say, well, yeah, I guess this is kind of epilepsy surgery. And these are these neuromodulation devices. So VNS, DBS, RNS, Dr. Abel will introduce us to those. And these are what we talk about when I say open up that surgery toolbox to see what's in there. I'm going to pass it off to Dr. Abel now, who will introduce us to what a comprehensive pre-surgical evaluation means in the non-invasive phase, which is phase 1.
Sorry, I'm muted. Thank you, Monica, and thank you for that wonderful introduction. It's really an honor to be able to talk about epilepsy surgery today. I'm a pediatric epilepsy surgeon at the University of Pittsburgh in our children's hospital, and I do about 120 epilepsy surgeries a year. And so in preparation for this talk, I actually sent an email out to all of our neurologists to get their view on epilepsy surgery for SYNGAP. And one of the things that I thought was really interesting is that one of them responded by saying, we've probably done more epilepsy surgery on patients with SYNGAP than we realize, but maybe we don't realize it because we haven't done genetic testing in all of our patients. So anyway, we're going to talk a little bit about evaluation for epilepsy surgery. And when this slide here goes over the phase 1 evaluation, which is when we're evaluating for epilepsy surgery, one of the most important things for us to do is to sort out if epilepsy is coming from one part of the brain or is coming from the brain more broadly, what we would term generalized epilepsy. And often these genetic epilepsies, like SYNGAP, are generalized epilepsies. But it's really important to establish that definitively before we plan an epilepsy surgery. And so what this typically involves is, you can see on the left, we do EEG, and many of you or all of you are familiar with EEG. We do a really detailed MRI study where we look at the brain in really high definition to try to see if there's an abnormality in the brain that's causing seizures. We do SPECT in PET imaging when it's available. There are many centers where most centers that are a level 4 epilepsy center will have a PET. And then some centers will also have a MEG and a SPECT, but that PET is really important, whereas the MEG and SPECT are not always necessary, but can sometimes add some information. But it's really important to go somewhere where you have these evaluation tools available so that you can get a complete evaluation. We can go to the next slide. So just because I think the point here is that just because you have a genetic epilepsy does not mean that you are not a candidate for epilepsy surgery. And there are many examples of this. There are some types of genetic epilepsies that are actually associated with focal abnormalities. And just because you have, for example, SYNGAP does not mean that there's not a focal abnormality causing seizures, which is why the phase 1 evaluation is really important. But also, genetic generalized epilepsies can also be successfully treated with different epilepsy surgery strategies, which we can talk about, I think, in some of the upcoming slides. Monica, is there anything else you'd like to add with the slide we just looked over?
We did a presentation with the Deep Connections group recently about surgeries for rare genetic epilepsy. And I think that's why I put it in the slide at the bottom, that please go over there to also look at that webinar, because it will share some of the data around surgeries for rare genetic epilepsies as well. That's it.
Great. And so there are several different types of epilepsy surgery, like Monica mentioned earlier. And I think when people think of epilepsy surgery, they typically think of a traditional type of epilepsy surgery where we're doing a craniotomy, meaning we're removing an area of bone over the brain, and then we're removing an area of the brain, sometimes a lobe, or disconnecting or removing a hemisphere, or sometimes we're removing a brain tumor or something like that. And that's traditionally what people think of when they think of epilepsy surgery. And that's those are some of the most common epilepsy surgeries that we still do today. There are other situations where we are just disconnecting that part of the brain. So rather than removing it, we're just disconnecting it so it's functionally removed, but not actually removing it. For abnormalities that are small, we can place a laser probe without doing a craniotomy to destroy that tissue. That's called laser ablation, or in some countries, and also sometimes in the United States, we do thermocoagulation, which is just another way of heating the brain to destroy it. But what's really important to recognize is in the last 30 years, but especially the last 10 years, there's really been an explosion in the availability of neuromodulation technology. And so these are technologies where rather than removing or destroying a part of the brain, we stimulate a nerve in the neck, or we stimulate the brain itself to try to decrease seizures. And I'm speaking about this in very broad terms, which we'll talk a little bit more in subsequent slides, but some of these strategies are associated with seizure freedom, and other strategies are just associated with decreasing seizures. But these different neuromodulation strategies can also be very effective. So sometimes the goal of epilepsy surgery is to achieve seizure freedom, and other times the goal of epilepsy surgery is to reduce seizures and improve quality of life. But really, the bottom line is that we really want to focus, especially these days, on improving quality of life and improving a child's development and thinking and cognition. And so one of the jobs of the epilepsy team and epilepsy surgery team is to assess patients holistically. And so we don't want to just consider someone's how many seizures someone's having, but how they're affecting their quality of life and what the patient and their family's goals are. And so sometimes I'll meet someone where their goal really is to be able to drive a car. And there's some surgeries that are not compatible with doing that. And so we try to consider all of those things together when we're making decisions with families. So with SYNGAP, there are 3 main seizure types: iclid myoclonia, absence seizures, and also tonic-clonic or drop attack seizures. Drop attack seizures are particularly important to talk about because they can be associated with head injuries and the need to wear a helmet, sometimes even use of a wheelchair, or anxiety about having another drop attack seizure. And so there are certain epilepsy surgery strategies that we think about in particular with these types of seizures. And so corpus callosotomy is a fancy term for one particular surgery that we use to treat drop attacks in particular. And what this consists of is traditionally making a small opening in the bone and then going between the two hemispheres of the brain to, do you see my mouse? Probably not. But to disconnect this structure in the middle of the two hemispheres here, which is called the corpus callosum. And the reason for doing that is that by disconnecting the corpus callosum, there's about a 60 to 70% chance that drop attack seizures will go away. Some other seizure types will also improve after a corpus callosotomy, but the main goal is often to treat drop attack seizures. And so there are now, even though this traditional way of doing a corpus callosotomy has been around for a long time, and you can see that approach on the left side of the screen here, this craniotomy, there are now multiple different ways to do a corpus callosotomy that are less invasive. And so one method is the endoscopic callosotomy that was pioneered by some people in Detroit, Sandeep Sood, and also Sandy Lamb in Chicago. But that's a way where rather than doing the traditional larger type of craniotomy, a smaller opening is made and a camera is placed, and that camera is used to disconnect the corpus callosum. And then more recently, we've begun using laser ablation methods where rather than even doing a small craniotomy, we just place 3 or 4 laser ablation probes into the brain using a special robot. And without doing a craniotomy, we're now able to do a corpus callosotomy. And so that's also now been quite common. And these less invasive techniques are probably just as effective as the traditional technique. Monica, am I going way too slow? Or are we doing okay on time? I think we're okay.
You're doing great.
Okay. This is data from a review article by George Ibrahim's group. George is a neurosurgeon at the University of Toronto, the Hospital for Sick Children. But it compares corpus callosotomy with vagus nerve stimulation, which are 2 different strategies for treating drop attack seizures. And what this shows, and what other models and other reviews have shown, are that corpus callosotomy is more effective for treating drop attack seizures. So here it's associated with about 70% seizure freedom from drop attack seizures, whereas VNS is associated with about 28% seizure freedom from drop attack seizures. And this data is very similar to what's also been seen in the adult systematic review, where it's about 70% for corpus callosotomy and 20% for vagus nerve stimulation. And so important to note, though, that these treatments are often used in combination. And so for someone with really severe drop attack seizures, we're often using corpus callosotomy, but then often using VNS, and we're often using them together. So even though we're comparing the effectiveness of these strategies, they're not mutually exclusive, meaning we don't have to choose between them. We can use both. And in many patients, we do use both. VNS and corpus callosotomy are associated with different rates of complications. And so for vagus nerve stimulation, you can get infection. Infection is probably the most common complication, which occurs in about 3% of patients. A small subset of patients will need additional surgery. But then common complications or adverse events are throat pain or coughing or drooling. Those are things that can happen because we're stimulating the vagus nerve and because we've done a surgery in the neck that are really common after VNS, but that are not usually, don't usually stop patients from using the therapy. Corpus callosotomy is associated with a higher rate of complications. About 13 in this series had temporary weakness. There's a high percentage of patients that have what's called the disconnection syndrome, which is where your personality is blunted for several months and your personality is just really off for a while, but then typically recovers. And about 2 to 3% of patients that are permanently affected by this disconnection syndrome. Now, it's important to note that these less invasive approaches like laser ablation or the endoscopic approach may be associated with lower rates of these callosotomy complications. But until we have more data, we won't be able to describe that very well. Vagus nerve stimulation is one of the most traditional forms of neuromodulation to treat epilepsy. And what it is, as you can see in this picture, is that we make a small opening in the neck where we place these stimulator leads on the vagus nerve, and then we tunnel those leads and connect them to a battery or pulse generator that's implanted kind of below the clavicle in the chest. It's always placed on the left side. And when I do about 50 of these procedures a year, and when I'm talking to families, what I usually say is that the most common risk of this surgery is there's about a 30% chance that it won't be effective for you in a way that's appreciable. But what that means is there's about a 70% chance that you will appreciate a benefit. And for about 60% of patients, there's about a 50% reduction in seizure frequency. And so cutting the seizures in half is typically what the studies that have studied VNS have considered as their outcome. And so there's about a 60% chance that you'll cut your seizures in half, and about a 10% chance of reducing them by about 90%. And then there's about a 5% chance of becoming seizure-free. But it's important to note that that's about the same odds that you'd become seizure-free even without an epilepsy surgery. Responsive neurostimulation is a relatively new strategy for treating drug-resistant epilepsy. And the advantage of responsive neurostimulation is that there are two advantages. One is that we're stimulating the brain directly. And the other advantage is that the electrodes that are implanted can actually sense when a seizure is starting. And then the device, which is implanted in the skull close to the brain, senses when the seizure is starting and then can deliver therapeutic stimulation in response to the seizure starting. And so this has become a really powerful method for reducing seizures in different types of epilepsies where, for example, if the seizures are arising from motor cortex, or the part of the brain that controls motor function, or the part of the brain that controls language function, and we can't remove those areas, this is a strategy where we can put electrodes directly on those areas and stimulate them to reduce the seizures. And so there have been a number of studies now that have studied RNS in children and have found that it's safe and effective with acceptable rates of adverse events. Now, for generalized epilepsy, groups are also using responsive neurostimulation, but rather than implanting it on the surface of the brain where the seizures are starting, they've been implanting the electrodes deeper in the brain in the thalamus, which is the brain's grand central station. And that's a way where RNS can detect seizures coming from anywhere in the brain and deliver a stimulation to a part of the brain that can then stop the seizure from spreading. And so that type of treatment is the topic of a large clinical trial right now, but preliminary studies have shown that this is maybe an effective treatment for generalized epilepsies. That's a good segue into discussing deep brain stimulation, which is a similar strategy to what I was just describing, where we're stimulating the brain's grand central station. And so when seizures are generalized and can come from anywhere in the brain, the strategy often, rather than trying to stimulate the brain surface itself, is to place electrodes into the thalamus, which is the brain's relay station. And by doing that, we're changing brain activity globally, which can reduce seizures. And this has been shown to be effective in Lennox-Gastaut type epilepsies and other generalized epilepsies. And so this is becoming a more and more commonly used strategy for treating generalized epilepsy, and some types of focal epilepsy also.
I just wanted to chime in. If you go to our YouTube channel, we have 2 other excellent videos that Dr. Abel has shared with us. Actually, they're sessions from our family conference. He did a terrific one in 2019 with Dr. George Ibrahim, whom he mentioned earlier. And then he did a kind of a follow-up to that this summer. And then there's also a great session on minimally invasive surgery with Dr. Sandy Lamb, whom he mentioned earlier as well, and Dr. David Adelson. So please feel free to go to our YouTube channel to learn a little bit more. And then also, like, I certainly don't, and I'm not endorsing the accuracy of any statements in these groups, but there are 2 big groups for pediatric epilepsy surgery, as well as RNS, DBS, and VNS on Facebook. If you pop into those groups and just want to see what some of the conversations are, you might be able to find some good information there. We should open up for questions for Dr. Abel.
Super. Thank you both. Thank you, Dr. Abel. Thanks, Monica. I know Lauren had a question, and then I've been exchanging a lot of texts. So SRF people, if you want to just talk, just message me. I can put you on, or if you prefer to type, put it in the Q&A. But Lauren, do you want to go first?
Sure. Yeah. So my son is 12. He's about to turn 13. He had a VNS placed when he was 4. So he's had it almost, this is going into his 9th year. He had intractable epilepsy and was failing drugs, all kinds of things. He's having drop seizures like crazy. He had like 100 in a day, in the morning. It was really bad. And they offered, other things, whatever, drugs weren't working. So we decided to go with the VNS, and like it cured his drop seizures. I know, and he has SYNGAP1. A lot of kids with SYNGAP1 aren't having as good of luck, I don't think, with it, but for some reason he is. It's been like a miracle, honestly, because he was dropping so much. So now that the VNS is getting older, we need to replace it, and I've been getting pushback. There's impedance on it. I guess whatever, it's just time, like it's getting old. We've had it for so long, but getting pushback that it's elective surgery, and he's starting to drop again, and he weighs 175 pounds. Like his drops are much different than they were when he was little. So I don't know. I think it's weird to me that they're considering an elective, but then I did finally meet with his neurosurgeon 2 weeks ago, and they actually just called me yesterday to schedule the VNS replacement, which is good. But in the meantime, I've been stressing out about it mostly. Like, why can't we replace this thing? And then now they're telling me maybe we should do the CC instead. Like that was an option. And I'm like, I don't really know what my question is. It's weird. I guess I'm just commenting that
So,
they would be saying that to me. Yeah, go ahead.
A couple things. And I'll speak in general terms so that I'm not
Okay.
providing any specific medical advice, but I'll speak in
Gotcha.
general terms and say that first, I think that VNS sometimes is considered elective surgery, but I think we need, as a field, we need to be a little bit careful about that because there's data now that shows that having VNS reduces the risk of sudden unexplained death in epilepsy. And so there's large population data that shows that VNS reduces the risk of death in epilepsy.
Yeah.
And we also know that, or we have a pretty good idea that when a VNS battery begins to get low, it's not as effective as when the battery is high. And so this is speaking in general terms, but if I had a patient who had a really good benefit from the VNS, I would make sure to replace the battery before considering other strategies.
Okay.
And it could be so. It's also important to recognize that I think it's good that I think it's always good to make sure that other strategies can also be considered because epilepsy is a progressive illness. And so I should say some types of epilepsies are progressive. And so sometimes VNS is enough for a while, but then you have to consider something more like DBS or RNS or a callosotomy. We think, based on just looking here and looking at one other center that we do collaborations with, that probably 60% of kids that get a VNS, or excuse me, that get a callosotomy have a VNS first.
Okay.
So VNS is typically the first step, but I think I would, in a situation where VNS worked really well, it may be good to see how the VNS works again after a battery change before considering other steps.
Okay. That's what I'm leaning towards too. Thank you. I appreciate that.
That's general advice.
Thank you. I appreciate it for sure. Got it.
It's really good what you said about the VNS and the batteries, because that is definitely the first step for a lot of our parents. I'm not sure so Sydney in the Q&A said, can you share more about DBS? Age restrictions, conditions for which it's on label, how hard is it to get access to the surgery if it's off label or if the kiddo's on the younger side?
Okay, this is the question from Sydney.
Yeah.
So I think the youngest I've ever heard of someone getting DBS, and it was not for epilepsy, it was for dystonia, is 18 months of age.
Wow.
So you can do DBS in a child that's very young, but this is tricky for a few reasons. One being that the skull is thin, which makes placing the electrodes a little bit more difficult. I've not placed DBS in a child that young. The youngest I've done is 3 years. So placing the electrodes can be a little bit more difficult, but also the head is still growing. And so it's possible that the electrodes can migrate. And so I think DBS should be considered in young children, but certain extra discussion needs to be had about what to do if the electrodes migrate, some of the challenges with placing the device, some of the increased risks. I think all of those things need to be considered carefully and also weighed against some of the other potential treatment options that are available for younger children. For example, we've studied our series of children who have had VNS at younger than age 6. And these children do have more complications than the older children that have had VNS. I know this question is specific to DBS, but probably some similarities between those two and just having some more risks at a younger age. And I think it is technically not FDA approved for children, but but that doesn't mean that it shouldn't be part of the armamentarium, because often when we get to a point when we're considering DBS, we often don't have other options. And so this is something that we are very direct with families about, but we still need to consider it. Now, that does make it more difficult to get approved by the insurance companies.
Yeah.
So the pre-approval process can be really difficult. For whatever reason, we haven't had too many issues here in Pittsburgh, but I've certainly heard of other groups where this has been an issue. And so from a health policy standpoint, this is for VNS, DBS, RNS, laser ablation, all these different strategies that are novel. And I think it's up to us in the medical community and also the health policy community to show that these are cost-effective strategies, because they probably, we need to figure this out, but they probably are cost-effective when we're considering how they change emergency room visits, how they change medication, the need for medication changes and things like that. And so, but this is something we need to figure out because it is a major issue.
Yeah, I'm going to move Sydney up to panelist to hit you with her next question, and then I have a couple for you. Actually, I'm going to Sydney, I'll let you go, and then I have a question.
Can I answer Nancy Kessler's question?
Sure.
It's so long-term VNS. You can have a CAT scan and an MRI. The more recent VNSs are MRI compatible, and CAT scan is no problem. So battery replacements happen once every about 3 to 10 years. That's a huge range in which you would need a battery replacement. The battery replacement surgeries are not as big as the initial surgery to place the leads in the neck, but there's still a surgery where you're placed under anesthesia, and there can be infections from those. So that is part of the long-term care. And I pushing on the neck, that's tricky. I would just try to discourage it and keep the neck padded if you can, but I also have a lot of patients that have struggled with this, and it has been okay. So anyway, I hope that answers your question.
Sydney?
Hi, everybody. Hi, Dr. Abel. My kiddo Emmett's actually a patient of Dr. Sagawa's at UPMC. So coming to you from Pittsburgh today.
Hey there.
I wanted to ask a second question to the first one about the DBS. Emmett, so my kiddo's 5 and he's severely refractory to every single medication we've ever tried. He has a VNS, but we've actually never had the SPECT, the PET, or the MEG, just a ton of EEGs and an MRI, which was, kind of unsurprisingly clean, as a lot of our Syngapians are. So I'm curious, should I be asking for all of these other studies, because surgery is going to always be on the table for us?
I think it depends on what your EEG results showed and what the MRI showed. And so if it's really clear that in the exact genetic testing results, sometimes those results would be clear enough that those other tests may not add much, but it really depends on your specific case. But it's something I would ask, you could always ask Dr. Sagawa about it. Since you're in Pittsburgh, I'm happy to look at those things for you also. But sometimes those things are not necessary.
No, that's great. I think that's what I was looking for, was just confirmation that we haven't accidentally left a stone unturned, and that I've gotten, good advice so far, even with a kid so complicated, by not having these things. And I guess I always kind of took it as, yes, the seizures are really bad, and so we don't need any more. We don't need to look at anything else to know that he's a candidate for surgery.
I have two questions for you, Dr. Abel, and I want to say that this is such a valuable talk, and even though we only have about 20 of us here, I know this webinar will be watched many, many times, because when parents get the genetic diagnosis, they get a bunch of drugs, and then some doctor suggests surgery, and they promptly freak out and call me. So now I'm so grateful to you and Monica, because I will point them to this webinar and then tell them to call me back. But what I've observed, and this isn't in the literature yet, but I expect it to get there, is some of our Syngapians who don't suffer from tonic-clonics around 18 tend to progress. And suddenly I've lost track of how many families told me at 18 they started having drops, right? And then so what happens is, in at least one case I'm familiar with, that's when they got a VNS. And now that the seizures are progressing and the VNS keeps getting turned up, and it's like a bad race, right? But the VNS isn't. And so I guess two questions on that. One is, an easy one is, when I just described that to you, genetic epilepsy, relatively manageable seizures until 18, suddenly radical progression, lots of drugs, not helping, add VNS, but not making a difference. And the kid's on a lot of drugs. Is that where you go to a CC or something? That's question one. But then question two is, there's some interesting research out right now. I think Juliet Knowles wrote a paper last year about epileptogenesis and what goes on in the brain. And over time, does the brain learn to seize? And tell me if I'm just being too random here, but is there a case to be made when you start thinking about, okay, what's going on in this brain and why does seizures progress over a lifetime, in getting some kind of neuromodulation, VNS, RNS, DBS, whatever, in sooner rather than later? Like in that hypothetical case, we have an 18-year-old and now we're in a race. What if we put in a VNS much sooner?
I think no one knows the answer to that question.
Okay.
Because the only way to have the answer to that question would be to do a study where you did that, where you took patients and you put in VNSs early, maybe earlier than you would normally, and then compared them to patients that didn't. But that would be the reason you couldn't do that is there's some ethical issues with doing that.
Right.
And it would just be a very difficult thing to do. So now there is some evidence that that the longer you're treated with neuromodulation, the more effective it is. And so there's this idea that maybe the brain even learns in response to getting the neuromodulation, and that changes the behavior of the epilepsy. I'm speaking in very broad terms.
Yep.
But I think these are like questions that are on the frontier that I hopefully we have better answers to in the next like 10, 20 years.
But in a sense, like you're right, we couldn't ethically do the study prospectively, but we could look retrospectively at, say, I think Lauren getting an EEG at 4 was pretty rare for our community. Pardon me, a VNS at 4 is pretty rare for our community. And that seemed to keep the seizures at bay. The battery dies, the seizures come back. We'll see what happens when we put the battery back. Maybe, anyway, I'm riffing. But it's hard to be a rare disease advocate and not wish you hadn't gotten an MD PhD at some point in the progression. I don't know if that resonates with Monica, but Nancy also asked a question about, is there a long-term effect to having the VNS in without a battery?
Can I interject real quick, just from a parent standpoint, just this whole issue of eventually what do the seizures do to the brain? And, there is literature on what's something called kindling, which is, if you keep seizing, are you then teaching the good neurons to seize as well? I know with removing half my son's brain, by the way, that was done in 3 surgeries. The first one, he was 3 months old. The goal was to stop the seizures. The second goal was, we did not want the bad deformed hemisphere to teach the good hemisphere how to seize. That was kind of the 2 things that we talked about with his surgeon, was stopping the seizures, but also we wanted to keep the good half that he did have that wasn't deformed, as healthy as possible so that, you know, that it wouldn't learn how to seize as well.
Got it. Dr. Abel, there's a bunch of questions in the Q&A. There's the Nancy question about leaving it in.
Yes. So leaving, if long-term effect, if the VNS is left in but not kept up. So generally, if a VNS runs out of batteries and is not effective, and we don't want to replace the battery, we typically would just leave it in place because there's no not necessarily any increased risk to leaving it there. But the surgery to remove a VNS is a lot bigger than the surgery to put it in. And that's because of all the scar tissue that develops around the VNS leads. So typically when I remove VNS leads, I recruit one of our head and neck surgeons, and it's a bigger surgery than just implanting it in the first place. So that's why we generally try to leave them in unless there's a good reason to remove it. I hope that answers your question.
Yep. And then this next one from Simon Bolta. Many Syngap. So the question here is just most of our kids, the phenotype, especially when they're young, is as you pointed out in your presentation, absence and myoclonia, but large clusters. And could a VNS be helpful with these if they haven't yet gone to drops?
Yes, I think so. Yeah. I think I would talk specifically with your neurologist about it, but in some cases, certainly.
And then Christy Burns, one of our parents, she points out her son had a CC at 2. I'm guessing before the Syngap diagnosis, and she wonders what not having a complete callosum will have any disadvantages with future brain development or cognition.
So this is a really good question. There may be some subtle issues, but I think it really depends on a lot of different things, like what is otherwise baseline function was, and those sorts of things. I have an 18-year-old who has epilepsy syndrome very similar to SYNGAP, who actually had a calcidomy at 18. And it did not affect her significantly. So even as an adult, sometimes you can have a calcidomy that will not have a major effect on cognition.
We have a VIP guest. Heidi G is making an observation. I'll let you comment. Other things to consider are how surgical interventions impact the network and progression. Puberty and hormones also have an impact on seizure increases. How does one, and I agree, I mean, I see all of our kids when puberty hits, it gets the behavior, because Syngap, there's a strong behavioral phenotype too. So you got the behaviors and the seizures both can get a little crazy with puberty. Is that something to think about as you time a potential surgical intervention? Or any other comments on Heidi's thought?
I think it's an important thought. I'm certainly not as much of an expert as my neurology colleagues on this aspect.
Fair enough. Christy says, thanks. So Ginny asks the question, are the surgery we're talking about also effective for generalized epilepsy?
Yes. Oh, good.
I'm assuming he's talking about the surgeries we've just discussed.
Yes. So in general, for generalized epilepsies, corpus calcidomy is generally considered for generalized epilepsies that include drop attack seizures.
Okay.
But corpus calcidomy can also be effective for generalized tonic-clonic seizures and bilateral tonic seizures. So it can be effective for different seizure types. VNS is also, we've looked at that in our data here at Pittsburgh, but other centers have as well, is also effective for generalized epilepsies. And that's typically what we use it for. DBS, specifically centromedian DBS, which is just one of the targets in the thalamus, is used for generalized epilepsy, and also centromedian RNS. And so each of those neuromodulation strategies is typically used for generalized epilepsy.
Great. And when people are considering this, I mean, there cannot be many people at your level, Dr. Abel. Like, do you encourage patients to go out and consult with other neurosurgeons? I mean, how many of your patients are local versus people who reach out to you for second opinions or assessments if they don't have access to this level of care at home?
I think this is tricky. So a lot of level 4 epilepsy centers have the capability to do these things, but I think like one of the first questions on the chat from Ed talks about surgery should be available and what are the restrictions. Part of the restrictions are just getting a referral, and I think there are multiple levels of how this can happen. There are some patient specific variables where you might just live really far away from a level 4 epilepsy center. Like when I was in Iowa, we just didn't have many pediatric neurologists. And so there were children with pretty severe epilepsies that were being treated by pediatricians out in the community and may have just not gotten referred. And then even at a busy level, sometimes even a level 4 epilepsy center, because a large proportion of pediatric neurology is epilepsy, there are some non-epilepsy experts that treat pediatric epilepsy, and they just might not refer for surgery. And so there are a number of different layers of barriers that can contribute. But I think it's one of those things where I think webinars like this are actually make a huge difference, because anyone can get on Facebook and see this and can then advocate for themselves just to make sure that these things are considered.
Yep.
That paper I mentioned in the beginning, that is a power paper. I mean, that is from the International League Against Epilepsy, saying once you're drug resistant, which is failing 2 appropriate and tolerated medications, you are supposed to be referred for a surgical evaluation. And doesn't mean you've decided to have surgery. It just means you are now ready to open that toolbox and work with a clinician, a surgeon, to try to figure out which one might work. Then you can go back with your family, the people who are close to you, and have a discussion about it. But not even referring over to be able to take a peek into that toolbox, I have a huge problem with that. I really do. It's unfair to our families that you're not even being told about the toolbox in the first place, or allowed to take a peek inside.
Speaking of the toolbox, people are texting me, and I'm telling them to just come and ask. But so I'm just trying to triage the Q&A here. So Ginny responds, son is 19, SYNGAP diagnosis 2.5 years ago with onset of grand mal, and his tonic-clonic seizures have increased to more than weekly over the past 6 months. Since VNS placement in October, he's now also having clusters of partials. So I'm not sure. That's a complicated case. I'm not sure if there's a question there. And then the other thing in here that's interesting, and I think germane to all these NDDs, Sandy says, sister had a DBS as an adult, she's able to communicate, so her doctors are able to tweak the DBS based on her communications. But with these nonverbal Syngapians who have varying levels of intellectual impairment, how do you tweak these neuromodulation devices?
Yeah, this is a really good question, and we have to do this with really careful observation. So this comes up a lot with DBS for dystonia, for example, where the globus pallidus, which is where the part of the brain where we put the electrodes, stimulating around it can cause different side effects. And in really young children, when we're slowly ramping up the stimulation, we watch carefully for whether or not their mouth is twitching. So a grown-up would be able to tell us that their mouth is twitching and that something's off, but instead we watch for it really carefully. And I think we would use a similar approach in patients that are not able to communicate as well.
Okay, so Sydney, you have a question, and then Olga, I see your hands up. Sydney, do you want to go?
Yeah, just one more. I know that like a lot of our doctors give us this progression, especially for the ones who have so many seizures. It's meds and then more meds and then keto and then VNS and then other forms of surgery, right? That's what I've been told. Monica, do you want to jump in and correct me? Because I see you shaking your head, go for it.
I'm going to stick my neck out. If you read through the literature, it's 2 meds and then a referral for a surgical evaluation. And then if your child is not a candidate, then keto. That's the progression. I think so this is where we're talking about barriers. A lot of neurologists see the look on the parent's face and said, oh, well, let's try diet or let's try VNS. And obviously I've come from, when we're looking at a spectrum of surgeries, there's VNS and then there's all the way to removing half of your child's brain. So please be mindful that my personal experience is also bringing a bias to this. But that is the progression. That is the step that you're supposed to go in. And that barrier to surgery, I mean, it's a big problem. It's a big problem if you live in an area, as Dr. Abel said, where maybe you only have one surgical facility nearby. If you're poor, if you don't have the right kind of insurance, if you don't speak English well, just all of these barriers that start to be put up. So I think it really becomes, from a parent standpoint, you have to be an advocate. You really have to be a strong advocate for your child and push for that referral.
I'm really glad that you said that, because I would dare to guess that most of us do not get a surgery consult after we fail 2 meds. Like very few of us probably. But I was wanting to kind of ask, like, what I've told you is, I think the progression that a lot of us are given for treatments. And I'm wondering, like, if we're talking about like surgery specifically, is there a kind of like progression that you would go through with regards to invasiveness? So like, I'm thinking it might be VNS, RNS, DBS, corpus callosotomy. Are we going to be asked to go through a progression like that, or will our team be looking more at like our child individually, their age, and of course all of that stuff, and then placing them into the surgery that they think is best?
So this is a really good question, and this also is kind of a similar question to one of the anonymous attendees asked. Given the heterogeneity in neuromodulation options, how do you choose between VNS, RNS, and DBS? And how heavily does the type of seizure impact the decision-making process? And so I think the bottom line right now is that this is something we're figuring out. And so we don't know for sure yet, because I think one thing I try to stress to families is that each of these different procedures are safe. And they all have what would be considered acceptable rates of adverse events. And so they're all safe. And so I think sometimes it's just a matter of discussing the pros and cons. I think at this point, most families and most of the epileptologists I work with still would consider VNS before RNS or DBS for a generalized epilepsy, just because that's what we have the most experience with. But then in the next 10 years, that might change. One time I also took care of a child of a neck doctor, an ENT, and they said that because they were an ENT, they've seen problems with VNSs, and so they just didn't want a VNS. And so we did RNS instead, and that was what the family was most comfortable with, and the child had good benefit from it. And so I think with limited information, there has to be shared decision making, and then also just being very direct and transparent about what we know as a field and what we don't know.
My son was super refractory as an infant. We had to put him into a coma, Sydney. Nothing would stop his seizures. when I think back to the decision making, both in the literature as well as how we made a decision as a family, it's what is our end goal? Do I want to do a surgery that has a 70% chance of stopping his epilepsy type? Or do I want to try something that has a 20% chance when we know nothing, no medication is going to stop it? So I think perhaps parent to parent, stepping back and first really defining what your end goal is. What is the seizure type you're trying to stop? How is it affecting your child? And then looking at the tools in the toolbox, which surgery is the one that is going to give them the most relief? And that's the one we chose. Yeah.
So we got so the thanks are starting to pour in. Nancy said thank you.
I can answer Avi's question.
Yeah, please.
So focused ultrasound is potentially a viable option for certain types of epilepsies, but and I know this because there was just a early stage clinical trial that was published in Epilepsia, but still a lot we don't know about it and are figuring out.
Got it. And Ginny just echoes the point previously made, 8 meds in her kiddo before VNS.
Yeah.
Heidi shared a cool paper. I think we got through the Q&A, guys. Olga, did you have a question? Yeah, go for it.
Yes, thank you, Mike. Thank you, Dr. Abel. Just a quick question. My son, we've been very fortunate in seizures have been controlled with medication. However, he's been on anti-epileptic since he's been 3. He's probably by his 3rd or 4th one, Lamictal works pretty well. But then at the age of 8, he started having drop seizures. So we added Onfi and have to continue, and that has helped with the drop seizures, but we have to continually increase that as he gets older and bigger. And I'm just wondering, he has a neurologist and then he has an epileptologist, but if we should consult with neurosurgery, I'm concerned about the long-lasting side effects of all these anti-epileptics. And if, it's epilepsy is progressive, is that something we should consider? Or I know it's a case-by-case basis, but it's never been offered to us to consult with neurosurgery or look at any other type of, procedures.
Yeah, I think absolutely. I think those things, it's good to discuss those things and know what the options are.
For sure.
Okay. Right.
Where do you live?
I'm in Houston. So I was wondering, is Texas Children's 11 for?
Oh, yeah.
Dan
We-
Curry or
Yeah.
Howard Weiner.
Yeah.
Okay.
sure.
Yeah. Dr.
They're
Weiner.
like
Okay.
world experts.
Okay, good. That's good to know. Thank you, because I haven't made it that far yet. That's where our neurologist and our epileptologist is, but okay. Thank you so much.
So I have one last one for you, Dr. Abel. One of the questions I get from parents, because Syngap is very fortunate in that, I say this to parents, and sometimes I say it to them too early. I say, congratulations on getting a diagnosis. And they look at me like I've got 2 heads because they're like, I just got a lifelong diagnosis for my child. I said, yeah, but now you know exactly what letter is wrong, and there are genetic therapies under development. And then I get questions like, hey, I might have a chance to get access to this drug, but there's an ASO that's a couple years away. Should I wait for the ASO? And as a rule, I say, if you have a chance to help your child reduce seizures today, you should pursue it. So with that as a setup, where's the discussion in the epilepsy surgery community with regard to those of us in the genetic epilepsy community? Like how do we say to a parent looking at a X-year-old where X is a single digit, who's holding hope for an ASO or a gene therapy, but has the chance to pursue an epilepsy surgery? It's a kind of hard question, but it can't be the first time you've heard some version of it.
Yeah, I think it depends. I think a lot of the epilepsy surgeries that we really are talking about today are things where the surgery we're doing does not make what we would think of as like an irreversible change.
Mm-hmm.
And so like VNS or RNS, certainly you can't undo a surgery once you've done it. And so there's that aspect of it that has to be carefully considered, but it's not a hemispherotomy or a lesionectomy or a lobectomy.
Right.
And so, so I think that the pros and cons of these approaches just need to be weighed, and I think for my child, I think if there was a risk of death from epilepsy and there was a treatment like VNS that could reduce that risk, I would want it as early as possible.
Yeah. Yeah, I'm always, whenever people say SUDEP, I always feel compelled to say that we have not had it, to our knowledge, because we're radically underdiagnosed, we've not had a Syngapian suffer from SUDEP, but it is still a serious thing. But I think a lot of families, as the seizures progress, which they tend to do, struggle mightily under the burden. And I'm glad we're having this conversation. I also like your answer in terms of framing a number of these interventions, the neuromodulation especially, is sort of not irreversible, and maybe inclusion exclusion for a trial, but would probably not prevent getting dosed with these gene therapies when they're available, right? It's hard to answer, but
one thing that I think is going to be really important is, as we become more aware of genetic epilepsies, we need to, and we need a lot more data, but we need to start stratifying our outcomes of surgeries based on what the genetics were.
yeah, I mean, is it standard practice for you to do exomes on all your patients when you operate? Probably not, right?
So that's usually something that if we have any suspicion, we try to do it before surgery, because also there's some things we can find that are associated with focal epilepsy and have us look even harder for a focus.
Right. Interesting.
But then there are also barriers like insurance barriers and things like that to getting genetic testing, or just personal belief, cultural barriers. So those are all things that come up.
Great. Thank you. We've gone over time. Grateful to both of you. Any last words?
Thanks a lot for having us, and thanks
Yeah,
to Monica
thank you.
for inviting me, and thank you to you for inviting me.
It was our privilege, and we love Monica. She's someone I ask her for advice sometimes.
Oh, my goodness.
Not
Thank you.
enough.
It's been an honor to be with your group, and anything we can do as an organization to further collaborate with you all, please, let's do it.
Great. And people who come to me with hard questions, I will just send you to Monica. So if you want to skip the step, just call Monica. She's fabulous. And I'm getting a lot of messages of thanks. So thank you both.
Thanks, everybody. Have a great day.
Take care.